aspiration and its interpretation?
I will rather like to change the title to just guideline of interpreting these things. But yes, most of the time my experience in this institute, because I really admit that the most of experience in bone marrows and bone marrow biopsy I got in this institute. As far as private practice was concerned, no. It was not possible to do bone marrows. And another thing, though I did my post-graduation from St. G.S. Medical College, which is a big institute, but the disadvantage in these institutes are that there is a separate hematology department, and they usually don't allow pathologists to interfere in their work. There is a lot of secrecy in that. This is my experience. I don't know what is your experience is. That may be differing. But of course, that time I could see few of the bone marrows because the person, Dr. M.B. Agrawal, who is a very well-known consultant hematologist, he was a lecturer. And that time he was very cooperative. Mostly what I see that most of the times, when you are getting the bone marrow and bone marrow biopsies, I have seen only biopsies being sent. Not only by the consultant, but even the so-called hematologists. If I give those biopsies or aspiration without the report of CBC or any history, can a hematologist give a diagnosis on that? At least they should have some consideration. But the problem is again with our department that we accept such biopsies without history, without age of the patients. The only thing written is bone marrow biopsy for histology or bone marrow aspiration for diagnosis without any history. And the most important is history and CBC report. Please don't accept any biopsy and don't interpret without CBC report. It is impossible. That is my experience. Now this also is covered. Now most of the time, either there are no fragments, or if the fragments are there, they are not properly spread out. And another thing what I have commonly observed is biopsy is not, or aspirations are not properly dried and fixed. And that gives rise to lots of artifacts and suboptimal staining. And that creates lots of, you have to really search the areas for of proper morphology of the cell in the whole slide to diagnose or to see the morphology of the cells. And mostly this problem is faced in the rainy seasons. This is not for aspiration, but even peripheral smears. If they are not dried immediately and properly, you don't have proper morphology. And why of this? You are facing this in even histopathology. Because even the xylene absorbs moisture and it becomes turbid and you don't get proper sections. So that is the optimum what is required. Another thing, what I am observing, that with all the scientific development, basically the skill of the person is being lost. And that is the basic. You really get very difficult to get a technician who is doing all the procedures properly. That's a real problem. And then yes, we have to depend on all modern techniques, that is cytoflowmetry and ISC and whatnot. Now, coming to, once the smears are prepared and stained, so you have to start the smear examination right from naked eye examination, that at least you can watch the fragments of the bone marrow in that. If more fragments are seen, yes, definitely the bone marrow is more cellular. If no fragments are seen, two things, there may be problems in the technique of aspirations, or it may be hypocellular. Then coming to, this is my habit that always scan the bone marrow, because the larger structures like granulomas or tumors or sometimes larger parasites like filarias, yes, we have seen filariasis in bone marrow, that can be seen. And again the background, particularly if there is a gelatinous transformation, you see that myxoid background in that. And another, only I have one case, that was amyloidosis. We had really difficulty, because if you go in books, it appears that diagnosis of amyloidosis on aspirations or even fine needle aspirations is very easy, but it is very difficult even on histology section unless you expect or you have seen it. This was a case, came with anemia, I don't know. This, for assessment of the anemia, bone marrow aspiration was sent. And there was in the background lot of bluish material was there. Then when we went to the history, it was a typical case of nephrotic syndrome. I don't know why they had not done the kidney biopsy. And on further history, of course, then we told them that is probably amyloidosis and do the kidney biopsy, that will be better, because we did not have other smears to send for Congo Red also. And on the history it was found that his brother also died of the same complaints 2 years back. Of course we did not get the patient again. So though from reading from the book it is easy to diagnose such thing, but when it comes to practically diagnosing a case, it is very difficult. So teaching is that way very easy rather than working clinically. So after low power, then of course you can choose the area where you can see the proper morphology and proper staining. And that proper staining depends on what stain you are comfortable, because if you go on listening to different consultant and different books, these may differ. What you are comfortable with is because I have seen plastic sections. Okay? And every cell appears malignant to me. After seeing paraffin section, it is not easy to interpret those plastic sections. So it all depends on your habit. And lastly, yes, you should go for oil immersions. Now, starting with, first you have to just assess the cellularity of the bone marrow, first is whether the smear is adequate or not. If the smears are hypocellular, reject it as inadequate, but because that is in benefit of the patients. And I think we are all working for patients, not for our egos or anything. But mostly in the practice it has been seen, because we talk about Bethesda system. How many of the people here are really reporting pap smear based on Bethesda system? If I start reporting today in this institute, 70% of the smears will be reported as inadequate. I am sure that is the ratio everywhere. 90%. Thank you very much. I am little conservative in talking like that. So ideal things are very difficult to follow. And those who are working and advising you to report like this, I have a doubt whether they are also reporting on that system. Because I have worked in different countries and I have found that this phenomena is world over, not only in India. We just blame ourselves that this is only in India, but this is found all over. Because humans are all over same, whether they are Americans, Britishers or Indians. Remember that. Okay, so coming to cellularity, that can be decided definitely on fragments. But if the fragments are properly stretched in the trails. On the trails, you can definitely report the cellularity. The fragments are not necessary if you properly prepare the smears. Okay? And mostly the properly prepared smears, as Dr. Kamal has said, the fragments are brought to the tail end. Because when you stretch them with the slice, they are taken to the tail end. Another thing is, then after deciding that, you have to count the myeloid cells, erythroid cells, ME ratio, that is also important, to determine whether there is a myeloproliferation or myelosuppression. If there is a hypocellularity and myeloid erythroid ratio is reversed, then there is a myelosuppression, not the erythroid hyperplasia. Like in cytopenias, I have seen many people, the total count is 4,000 and 90% lymphocyte. You don't call it lymphocytosis. It is neutropenia. Same thing should be followed here. So, then going to different series, then you have to study different series, that is myeloid, erythroid. Then in the scanners also you can watch giant cell. Now I have always found a difficulty to decide whether these giant cells are megakaryocytes or the inflammatory giant cell. It is very difficult. This has been my experience. Because sometimes the megakaryocytes, though most of the time they show lobe nucleus, they show distinct nuclei like giant cells, and the osteoclasts, which are rarely seen, of course. But tuberculous granulomas, yes, the giant cells have been reported, and we have seen in our institute also. Okay, so we have to see. Then another is plasma cells, parasites. As far as parasites are concerned, yes, leishmaniasis is almost not seen in countries, but we have reported 2 cases from our institute. Both of them were migrants from Bihar. Then filariasis, yes, in a case that you will be seeing in chronic myeloid leukemia. As far as malaria, now there are newer techniques. But I had a case, a child suffering from fever for almost a month. After giving anti-malarial, antibiotics, everything, not responding. And then that was in Cooper Hospital when the bone marrow was done, frank malarial parasites were seen. So particularly in cases of pyrexia of unknown origin going on for a long time, it is advisable to do this. Besides that, in many times we have found malarial parasites in bone marrow which were not detected even with malaria antigen. This is my experience. What books are saying, I don't know. Okay. So these are, and lastly, iron stores, particularly important in the assessment of anemias. Now these are the smears, badly prepared, though there are multiple fragment scenes, but they are not on the tail end, they are on side of the base of the smear. That means they have not been properly pulled. This smear, if you go, the fragments are less, but if you see the microscopic cellularity of this smear, it is better than the above smear. This is what is seen in, and these are technical problems, nothing else. Now coming to cellularity, we have already discussed. Then marrow can be, of course, you need not write in the report. What you report is hypercellular